What's up, everybody? It's Mark Cardle, your host of the Modern Pain Podcast. Just coming at you this week with an interview of a friend and colleague, Mark Shepard. Mark is the Fellowship Director for Bell & Health, formerly EIM's Fellowship Program. He's a colleague and friend. We both went through Fellowship at about the same time. Mark has really done an amazing job with leadership. He's obviously directing the Fellowship. He's very active in the APTA and within the orthopedic section, and has really spearheaded, along with a group of other clinicians and folks, pain education manual, which has been a great help to the academics out there who are trying to incorporate pain science into their curriculum, as we all should be. He's doing some good things, like I said, and we talked a lot about expertise and how Fellowship impacted us, the value of mentorship. We also talk about some of the questions on, does expertise best sit in a manual therapy fellowship, or should we look a little more broadly at musculoskeletal or orthopedic-based fellowships? And I thought Mark had some great answers there. So I hope you guys enjoy the episode. I think a lot to take from this as far as some of the bumps we've had in our journey and where mentorship served us. Hope you enjoy the episode.
This is the Modern Pain Podcast.
Mark, welcome to the podcast.
Thanks, man. Happy to be here.
You know, man, it was good catching up with you at CSM, although brief, as it always is. You're busy, and I'm flying around, so it wasn't as long of a catch up as I would like. But hey, we'll catch up over the podcast. We'll see how life's going. But just a little lead up, and I'll have a little intro obviously before this. But Mark and I kind of went through a very similar journey. His name's also Mark, so he's obviously got to be a good dude. As far as training and growth in physical therapy. So I wanted to get him on because he's done some good things. He's pretty active in the ortho section, pain section, and has helped really boost our education in pain throughout our academia with his pain education manual that he helped spearhead, which we'll talk about. But also has gone through the manual therapy journey, and I think he's I think he shares some similar thoughts as me. So, of course, that's why we have him on the podcast, because we don't want any dissenting opinions on this podcast. But, Mark, why don't you just introduce folks a little bit to yourself and, you don't have to go into the nitty gritty every step of the journey, but, some of the, journey and what you're up to now.
Yeah. So my main role currently is serving as program director of Bell & College's Orthopedic and Manual Physical Therapy Fellowship. I also spend part of my time in their DPT program. I teach hybrid classes in that DPT program. So Bell & College is in Green Bay, Wisconsin. I live outside Baltimore, Maryland. I've been in this area for close to 15 years. I've been practicing PT for about 13 years. And since that time, I came right into the field. I was like gung-ho. I knew I wanted to go in to orthopedics. When I was in PT school, I did not want to go that route, and soon met the likes of Tom Denninger, who was 2 years ahead of me in PT school. And Tom was a mentor to me as a student and as a new graduate. And I just kind of followed in his footsteps because he was kind of the person I looked up to. So he did residency. I was like, look at Tom, I want to do residency. And Tom went on to do fellowship. And I was like, it's the way to go. And a lot of it was looking at the research at the time, as you know, Mark, was filled with the same names. And a lot of those names were associated with one program. And that was a program you and I both found ourselves in. That program opened up tons of opportunities for myself. And I got very close and still am close with Dr. Julie Whitman, who was the program director before myself. And really, she was the one who opened up that door for me to step in. And, since that time, got really involved with just learning more about pain. I think fellowship opened my eyes up to the complexities of patients out there. And I realized there was still more to learn. And so I went through the TPS program at EIM with Adrian, and Corey Zimney was a huge person in that program for me, just teaching me a ton about pain. I got a fair bit of it in fellowship, as you know, but this really honed in on my skill set, and then just got, clinic. I just kept using it and refining it, failing, using it, refining it, failing. And it just led me down the path I am today, which I've become pretty passionate about lifestyle medicine. And as you know, Mark, pain, you can't deny nutrition, sleep, physical activity when you're treating people with persistent pain. So That's kind of where I've been doing a lot of my growth over the past 3 years, is just learning more about those areas of behavior. And I've been putting a lot of my research efforts into sleep and pain, and tying that back into how we can use that as orthopedic manual physical therapists. I've been obviously working with you, Mark, for a long time now, 10 plus years. And you've been a mentor to me, and listened to this podcast for a very long time. And, I always think you push the envelope and have pushed my mind to expand in many different ways. And I think a lot of that has trickled down to where I am today. So thanks for pushing the envelope and challenging our biases.
Well, hey, you've challenged my biases as well. I think it's been a equal opportunity. I think we both have, our own opinions and thoughts. And I think, you articulate them very well, and you've done some great things. Obviously, taking the torch that Julie Whitman passed to me. Julie is a great person. Fortunate to get to know Julie a bit. Obviously, you're close with her and have taken over the program that was once EIM and now is Bellin College, but same program and the same great. It was a great life-changing experience for me. I think it was the first tip of understanding man, there's a lot more to it than just, the manual therapy components of it, the pain parts, and where does manual therapy fit in with that? Yep. I'm just curious, with that said, and as you've seen things even in the last 10 years, and being quite involved in fellowship education, obviously not just with Bellin, but also probably seeing what's going on around the country when you're meeting with the other fellowship directors. What's been your view on kind of how things have kind of progressed? I know probably there's some good and bad examples of that type of thing, but how do you think the education around pain has progressed in fellowship?
I think you'll see the spectrum. Honestly, you see people who are more focused on the biomechanical aspect, of the biopsychosocial approach. And then you'll see kind of the other end where people are really focused on the psychosocial and not so much the biologic aspect of it. So it's finding that balance. I think, you can agree that the pendulum swings a lot in what we do. And so what I've really tried to keep my foresight on is how can we balance that piece? And really challenging myself in a program is how can we get people who are very well versed in all those different areas to be involved. So you're very familiar with Marcos Lopez, who does a lot of our pain content. Travis Gunderson out of TRIA in Minneapolis area is also involved. So they kind of spearhead a lot of the pain specific content. But, we really are trying to understand in our program how to balance that. But, I think pain over the past decade, we've learned a lot. I think a lot of programs have really taken it and run with it. But I think, as an evolution of our program, we've really worked to become what we call person-centered. And you've had Dave Poulter on, a couple episodes back, and he's been a huge proponent of this. And the first time I heard person-centered ever used was actually a nurse, the president of Bellin College, came in and was like, it's not patient-centered, it's person-centered care. And I was like, who cares about the words, And, I was looking at, what Dave tweets, and he had a really nice thread a year or two ago about the difference between patient and person-centered. It just really hit home, and I've really bought into that. And I think he's said even now it's person-focused is kind of the term that he's been using, which I like. And so when you look at a person as a whole, you can't help but not use a biopsychosocial approach. And so I like to think that our program is conceptualizing what that means. And to me, it's you have to develop your hypotheses in a way that makes that fit. And my experience with other programs is that you'll see a lot of that. I know just talking to people, Kaiser's program is very much in on it too. And several others that are very much like, this is the way we need to go. We need to look at the other person as a human and see that there's much more than stiff joints and things of the like, And so that's kind of where I feel like things are heading. Our program hopefully is trying to stay on the leading edge there, but always work to do. New stuff coming out, new ideas, and how we implement that is important, I think.
Well, that's the thing that's always been impressive with the IAM and now Bellin, as far as keeping on top of that, the front line of what's coming out in the research and incorporating it, and not just, this is the way we do it, and this is the, things just stay stagnant and research passes us by and we become obsolete. It's been, nice to see demonstrations of programs keeping up with it. And I know you're very much a big proponent of that. And we mentioned this a little bit before we went on and started recording, and I've always had questions, and I'm just curious what your thought is, as obviously a fellowship director. And I think fellowship training is amazing. It's been, the clinical reasoning and just critical thinking components, I think, were the biggest things. I mean, the manual therapy was kind of secondary. And of course, we know the research kind of says, okay, is that manual therapy approach? I don't think there's any approach, be it manual therapy or any other type, intervention that's really shown on its own capacity to make a major difference, as we wouldn't expect anyway, because people are complex. But I'm just curious with the way we're seeing things kind of really, or I don't want to say manual therapies because it's gotten bashed unnecessarily. I think the folks that might, anything with a pulse and pain gets manual therapy, I could see that might get a little bit of some criticism. But I think when you use it judiciously in a person-focused manner where it fits that kind of paternalistic desire of a patient, and different things that might, for certain patients, might be there. But I'm just curious if you see long-term is our expertise, if we say what's the demonstration of the highest level expert in physical therapy, is that best housed under a manual therapy umbrella, or would it be better off? And my thoughts have always, have been fellowship in orthopedics or fellowship in primary care, to where it's more, we're seeing the broad picture. I just think, is there some risk when we have this under just the manual therapy kind of method or kind of approach, that we kind of limit maybe its exposure to folks who, hey, I want to be an expert clinician, but I just don't think manual therapy is the road I want to go.
Yeah.
What are your thoughts? Where do you see clinical expertise, and is fellowships sitting under that umbrella still the best place for that to sit?
It's a great question. It's an ongoing dialogue. Actually, IFOMT was looking at changing their name to be more of a fellowship of musculoskeletal care or musculoskeletal practice. And it was very, very close to passing. And I will say that AOMT was adamantly against going in that direction. And a lot of it was just due to, we are a specialty. Manual therapy is a specialty. And I think where I see a delineation in some of this is it's manual therapy versus manual technique. I think a lot of people see manual therapy as the technique. But I know people like Dan Rohn, I think Paul Minkin, Josh Cleland are redefining what manual therapy is in a modern view. And that, as you probably heard, is one that takes into account, the biopsychosocial approach and exercise. And to me, just like physical therapy is not just exercise, it's the component and the decision-making around it. I see manual therapy as expertise in understanding when, and more importantly, when not to use a manual technique. And I think what I see and what I appreciate about you, Mark, is what I've experienced after fellowship. And I tell fellows in training this too, is that after fellowship, you become more precise with what you do, including manual therapy. I use it a lot less than I did, but I use it more precisely. And that's because with using a test, treat, retest approach, and then understanding the pain mechanism that person may have, you may say, well, if this person is nociplastic and has a lot of hypersensitivity, am I going to go in there and start bouncing on someone's spine when their conditioned pain modulation is absolutely not working, when it's just going to ramp up and cause temporal summation? No. Will I use it in someone who has more nociceptive kind of pain mechanisms? Yeah, it's probably favorable in that circumstance. So to me, it's made me more precise. So I think where a lot of people bash manual therapy is they bash the absolute application of manual techniques without precision-based dosage And so to me, the specialty and the expertise sits in there. And then if we look at manual therapy as a decision-making approach, I think it can be brought out amongst multiple different areas like neurologic style application, pain application. But, it's hard because I have a hard time sometimes committing to one side or the other because I can hear the other person say, well, it's got some valid points. And then I listen to other people. I'm like, those are good valid points too. But I think me personally, where I sit is I look at the differentiation between the technique versus the therapy approach. And that's what I feel more comfortable with now in modern day is that, it's the approach behind when you're using that in addition to other evidence-informed approaches like exercise, pain education, graded exposure, cognitive functional therapy, dry needling potentially, So there's a smorgasbord of other things, but it's where does it fit in and how do you reason through that approach?
Yeah, no, I definitely would agree with you as far as like it is the thinking and the reasoning and the choosing the right intervention for the right patient at the right time. And it's not based on how good you think you can lock out a facet from 14 different planes of motion and all these different things. And I think back to I've been very fortunate. I know you would agree, like the ability to interact with people like Barb Stevens and Tim Farron and some other folks that are involved in the program and I remember, and I've been working with them and being fortunate to get mentored by some.
Yeah.
You'd see some of these techniques, and I remember, I think it was Barb Stevens who said, Maitland used to say, you got to find the hurt and hurt it. They're like, oh my God. But then I'm like, well, you know what? He was just seeing clinically the phenomenon of diffuse noxious inhibitory control. When you blast somebody with painful stimulus, now, of course, he's not blasting. He's doing it therapeutically and for good, intentions and therapeutic intentions. But I think science and pain science has started to explain what, a lot of these clinicians were seeing in the clinic. I think it's also, given us some ideas of when maybe, hey, just constant trying to reason and kind of move somebody with just that hands-on approach may not be the best approach for some folks. And it's been cool to see, Bellin and a lot of the programs getting into, as you mentioned, lifestyle medicine. I think that's one of the big things that I speak with any of my folks who are dealing with persistent pain is like, you got to look, you got a bunch of folks in healthcare who are going to talk to you about one tree in your amazingly complex forest. And you need to be looking at the forest, which is your lifestyle and all these things. And with your work on sleep, I'm just curious, like if you can let us in on a little bit of what you've been doing and maybe what you got in the pipeline as far as what you're looking at as far as sleep. Because I think, you hear PT say we got to do it, but I don't think there's a lot of folks who feel comfortable either broaching that topic, how it goes clinically and all that stuff. But maybe you can shed some light on it as far as what you're up to and how you go about it.
Yeah, every time I talk to people, especially physical therapists, about addressing sleep, I always say it's the last thing that people will expect when they come to physical therapy. But every time I broach it, as simple as when I'm talking through the interview and looking at 24-hour behavior, it's a natural thing. We always ask about, how are you sleeping, right? And we think more of it, are you painful? Are you comfortable? But I expand upon that, and say, how many hours are you sleeping? And do you feel well rested the next day when you wake up or whenever you wake up? And it opens a conversation to understand what may be going on there. And Brett Nielsen and I worked on a study when we were in the DSC program, and we were looking at sleep attitudes and beliefs in those with spine pain. So basically neck all the way down to sacrum. And we had roughly 200 subjects across the country. 50% of them had dysfunctional sleep. And a lot of them were getting less than 6 hours of sleep per night. So it tells me that, if you look at just extrapolating this to your clinical practice, if you see 200 spine patients over a couple months, roughly half of them probably have sleep impairments and dysfunctional beliefs about sleep. And so to me, it's just showing the importance. Is it every person that comes in with back pain? No, but it's, at least half of them from what we've seen in our preliminary data. And so to me, if we're not looking at it, then we're missing a big cog in their pain experience. And, I've battled over this, like, what is the most important behavior of them all, that we need to prioritize. And, my bias, of course, is going to be sleep because that's where I hang my hat. But, you get other people who say it's exercise, you got to exercise. And other people say, oh, it's nutrition, what we eat. I think that's a huge piece. But, sleep to me, if you're not getting good sleep, you're not making good decisions or can't make good decisions about what you eat, and you're not going to feel well rested enough to even want or be motivated to exercise. So to me, it's kind of the biggest piece that you should try to look to get. And so interestingly, and kind of where my mind and others, I know Brett Nielsen and I have been kind of batting this around, this idea of catastrophization. And, a lot of what we see in sleep is people are really anxious. And a lot of what we saw in their beliefs about sleep were actually rumination about sleep, that they felt like they had to get 8 hours, and they felt like if they didn't get sleep that they would be in terrible shape. And it's kind of reminded us of like, oh, that's what like people think about back pain. I have a slipped disc, so, my back is going to fall apart. So we're wondering, and we want to look at if there's a correlation between beliefs about sleep and pain catastrophization, and if the two kind of play into each other. Because in that, line of thought, you could do a lot of work to educate people about, sleep and the flexibility behind sleep to minimize and decrease anxiety, because obviously sleep plays into that as well. It's interweaved in the pain experience. It's interweaved in what we're seeing. And as Barb Stevens would often say about sinister pathologies, you may not be seeing it, but it is seeing you. So if you're not asking about it, it's out there. It's just whether you feel intrigued enough or curious enough to ask about it. And, part of what I would like to do, and Katie Ciancicon is a huge, she really opened up the world for Brett and I and others about it in PT. And so she's been on a mission to try to get this, more front and center in PT care. And luckily at Bellin College, I'm currently teaching a lifestyle medicine course where we, have several weeks worth dedicated to sleep, nutrition, motivational interviewing, and the like. So hopefully we're turning the tide a little bit and getting this more front and center from the start. It's just getting practitioners to feel comfortable with it now.
Yeah, no, I love it. I think definitely the lifestyle medicine approach that you speak of, obviously sleep being one of the pillars of that, I think is huge. And you bring up some good points. It's hard to like put sleep on an island and not recognize that, somebody's social existence, their stress management abilities, their movement habits, their nutrition, all those things are going to play a role in the sleep. So it's hard to like, you're not going to necessarily fix sleep if you don't understand the other components of what's going on with that. And that's what makes it like fun in the clinic is like that whole, I remember Peter O'Sullivan said is that the patient arrives with like a jigsaw puzzle full of pieces, a box full of them, and you got to figure out where it all goes together and kind of sit down with the patient and work and see where those pieces all fit together with the patient as an equal expert in the situation. So yeah, no, I love the fact that you guys are doing more and more of that. And I think sending clinicians out that are well-versed and able to have those conversations. And you mentioned Barb Stevens. Barb Stevens should have a quote book as far as like, and she's always full of good, quotes of wisdom by Barb Stevens. PT. She is one of the more well-traveled and smart PTs I've ever had the, privilege of getting to know and getting to learn from. So props to Barb for pushing our brains the way she did. I still remember, and this Mark and I are going to ruminate or reminisce about our fellowship days, but we would sit and get grilled underneath the, I came in with an ego, as most do, where I thought, I got things figured out and I think I'm a pretty damn good clinician already. And then we had these virtual rounds where we'd present a case to like with Tom Denninger was in the audience. I remember for mine, Jason Steer, a couple other friends. And I remember it was Tim Fear and Barb Stevens and Britt Smith. And it was like Tom actually came out of his first case pretty well, but like we had to present 3. I remember Jason Steer and I both after each of our cases, like, oh, dude, it was so depressing. I just got absolutely in a very professional mode, but it was such a humble experience. And it's one of the things that I think taught in fellowship and where you just get that like intellectual humility to realize, one, you don't know nearly what you think you know. And in any stage of your career. There's just so much to know. And as you see the research just exploding day by day, you're never going to keep up. My to-read list never gets smaller. It continues to grow. But what an experience to have that. And I'm curious too, like, what's your thoughts on mentorship? Because I've had these discussions. I think I talked a little bit about on our last podcast. This, and you kind of alluded to it earlier, like this push, like I got to learn the next technique, like the newest thing. I'm not against dry needling. I'm a little irked by how popular it become, to where some therapists have thrown away the ability to, like, again, just maybe like I did with manual therapy in my career, to see, like, okay, where does it fit? And, it should be a supporting cast member versus the star of the show. Yeah. But, mentorship being such a huge thing for growth. And I think it's just one of those things that I wish I would have pursued that more aggressively early on. I spent 10 years trying to, fix things by putting more letters after my names with more techniques. But I'm just curious, what are your views on mentorship and how it kind of impacted you, and what you think folks out there should be looking at in the form of mentorship?
Yeah. And, I listened to your last podcast, about your own personal growth, and what, you had said, I wish I got to mentorship sooner. And, to me, mentorship is the game changer when it comes to changing your behaviors. And so when you look at our program, Bellin College's program is one of the longest to go through. And we have probably one of the longer dedicated tracks within our curriculum, totally to clinical reasoning. It's almost a year's worth of coursework dedicated solely to clinical reasoning. And so to me, you're doing behavior change, and you know how that feels, right, Mark? Like you're saying, you first have to be stripped down to become curious and humble, so that you're being open to your own biases and heuristics and errors in your critical thinking, and then allow for mentorship over a long period of time. So for what we, all fellowships have a minimum of 150 hours of mentorship. Our fellowship has probably tacked on to that because of the clinical reasoning work we do. But to me, you need time to allow for those behaviors to change. Even if you do mentorship consistently for a couple months, it's very easy to fall back into behaviors and patterns that you had even as soon as like 2 or 3 months in clinical practice. And so you really have to hold your feet to the fire, I think, over a longer period of time in order to truly make behavior change. Because when you look at patient care, not everybody is willing to change their behaviors. And some are very willing, but they need the extra reps and repetition to make it sit as a habit. And then others who are a little bit more resistant to it, they want to, but they're not really all bought in. You need to give them time to figure that piece out. And the mentorship allows for that to happen. It's a person to guide you and push you at the speed at which you want. But to me, you need time for that to happen. And so, Con Ed, you get blasted immersively over a weekend, or if you do like a cluster of 4 weekend intensives, if you will, over a period of time, you're going to learn some things, and you'll probably utilize 2% of it, 3% of it over that period of time that you consistently utilize. But again, to me, that is technique focused, where you learn the shiny thing and you do it on people, but it's not therapy focused, meaning the reasoning behind the technique or the thing that you learn. Just like motivational interviewing, there may be 3 behaviors or practices you get out of a class with that you might use, but with mentorship and time and consistent accountability, you have to hold your feet to the fire. And it's much harder. I'm not saying every one of our graduates is like perfect with our reasoning model, but I will say it's harder for them, and they feel a lot more guilty about cutting corners and falling into confirmation biases and things like that plague, as you know, plague all of healthcare, every facet of it. But to me, fellowship and mentorship, I had Andrew Bennett as my mentor and Paul Minkin, but Andrew was really my main guy. And there were some times where I wanted to get underneath the plinth and just hide. But that those experiences, the intellectual honesty to me allowed me to be curious. And I learned more after fellowship because of the reasoning model and being curious and the mentorship I had, so that I continued to learn my own way. And so when I learned dry needling, I didn't turn a patient into, a dartboard and say, all right, I'm just going to put 20 needles into someone's calf. Of course you're going to make a change. You just riddled their nervous system with a barrage of input. Anybody's going to have a change with that. But, I always say mentorship and fellowship allowed me to be a clinical sniper instead of a clinical person who uses a mortar blast to take things out. And it's a kind of a terrible analogy, but in my mind, it's like precision. It's made me more precise, or at least think more precise. And even with my manual therapy, there's plenty of literature out there that says that specificity is not attainable by what we do. We're not mobilizing L3 on L4 only. When we're in the neck, we're probably mobilizing a couple segments down or below or whatever, right? But I always tell folks, even myself, is like, even though we can't be specific, it doesn't mean we shouldn't try. Yeah. And I think that has just made me more intentional in my thought process and with my touch. And so again, it's these nuances, I think, that have been opened up to me through mentorship and through fellowship. And I'm sure, I'm curious to hear, you said yourself, in your last podcast that it was there. I mean, what did you experience from your standpoint with mentorship?
Similar things. I had Tim for a good chunk of mine, Tim Farron, who's a good friend, and, definitely pushes you to think, and is one of the bigger proponents of having therapists that think, and not just, our technicians doing the mortar blast. I always said chucking mud on the wall approach, where, of course, if you entertain symptoms long enough, people are going to get better a good chunk of the time. Just good natural history and regression, are good friends of all clinicians. And again, we own that, and you realize it, and take, it's not necessarily a bad thing, but it was, I agree. I honestly, if I look back, if I could have had that like 3 years, 4 years into my career, and then took on all this stuff, and because then your bullshit filter is so much better. Because then, you know what, because you got to take, once you have this good critical thinking and clinical reasoning model, all these techniques and new things have to pass the bullshit filter. And you know who the person that's going to tell you if it's bullshit? It's the person in front of you that N=1 study that you have every interaction you have with a patient, and you get to see, versus, again, where this is my thing I do, and I do it to everybody. And I think when you can be that precise clinician of being able to fit yourself, be it manual therapy, be it pain neuroscience education, be it exposure with control, psychologically informed, whatever it may be. I just think you learn a lot better approach to figure out how to stage a patient of where they're at and what they're ready to go into, and what's going to be your best choice for that patient each day. And then you also get like, okay, I got plan B, C. I remember, we have students who come into our clinic at Midwestern, and, I try to encourage it, but then I always think like, man, dude, you're asking them to think like to visit like plan B and C in the clinic. Like you need to just keep it simple. But you have that as you get through fellowship, as far as like, this is plan A, but I got plan B and C in the holster that I'll be going to if this doesn't work. The thinking, I can't emphasize enough. And was a huge thing for me. And it allowed me to kind of, filter out the stuff out there in the PT world of the fluff, and what's worth maybe the time to spend on reading stuff or going to a weekend course on things. And then also putting, like you said, weekend courses into perspective of what they're. Sure, you might learn some techniques, and you get to find out, hey, in my N=1 scenario with my biases and the population I serve, does it fit? And you get to test it, and you have a good process that you learn to test it, and see if you're just learning techniques that are, not really worth anything, or, hey, it really makes change with your patients. Of course, we can get into discussions of what's behind change and all these different things. But yeah, no, I can definitely relate to you of the one in the crawl under the table. I think there was that, and Jason Steer, who's one of my favorite people. He's the most humble, soft-spoken dude, but one of the more brilliant dudes I know. I hope he listens. Yeah, him and I both took it hard. He took it super hard that first thing, but him and I were like moral support. Like I think we were doing like psychology with each other after those first few virtual round cases, because we were just both felt beaten. And on look back, it was a great experience. I needed it for sure.
Yeah.
To bring me down to a level, like you said, strip you down so you can get built up with a better approach with things. But I think we've talked a bit about like the younger clinicians, but I'm just curious what do you see out there? Maybe some things that, I don't know, maybe concern you or things that you're really looking at our younger generation. Dude, it's hard to believe I'm going to be 20 years. Well, I am 20 years this month. It'll be me in the profession, which seems crazy to me. But I'm just curious what you see in the young generations and some of the challenges they face and the things you'd recommend for them as they're charting their path of growth.
Yeah, it's such a good question. And I think part of the challenge, this wasn't really around as much when we were, starting out our practice, but there's so much information out there. In the early 2000s, there were no articles really that were like what I got when I came out in 2010. And I was like lucky enough to have a lot of literature that kind of guided me in a direction as a new grad. But now there's a lot of literature out there. There's a lot of social media out there. It's really easy to be entertained and sucked into something based off of what you see on social media. And that's the easiest way I think most people are consuming information right now. And so, I think I've learned sometimes the hard way that when you look at people on social media, you think that they're doing something really well and they're not. And this well too, Mark, just from your experiences too, and being involved with modern pain care is like you see people and you're like, oh, they're doing legit stuff, and then when you find out truly what's happening, it's like, oh, this is totally different. Social media is the mirror of what we want to be, what we think we should be. And so I think a lot of new grads sometimes see these videos of fancy exercises or, these posts about, manipulation, this, dry needling, this, pain science, this, it makes it look easier than it is. And we all know, it's a complex world out there. And I think even treating people in the musculoskeletal realm has gotten infinitely harder over the past 40 years because of the complexities of society these days. And so, I think there was probably total conjuring up here, but there's probably a lot of more nociceptive pain states back in the day that responded really, really well to our, manual therapies of the world, exercises of the world for the most part. But now, with the rising opioid epidemic or pandemic, and then just the way society and mental health is right now, the filter of our peripheral inputs is totally jacked because of those things. And so I think, for people that are out in the field, they'll get people better, but, with some of these things they may see or read about, but the complex cases who desperately need our help are the ones that are going to be tough for them. And I think also with the amount of debt people are coming out with, they don't have the bandwidth necessarily financially to go through post-professional programs or mentorship even. And so that's a concern. And even the cognitive load, I notice even from 10 years ago, even fellows coming in, the amount of stuff that they have to get over because they're run down in the clinic. I mean, they're working for a place where they're multitasking. They're seeing a ton of people. They're trying to get notes done so they don't have to do it when they go home. These things don't lend themselves to reflective, metacognitive, clinical reasoning. And so that's what I say with a lot of our behavior change is we're breaking people from, this double booking, having two people at once. I know it's a model for places out there. It's dangerous for what we have to do. And I totally get it. No money, no mission, you can't run. But why are we bending what should be ideal practice? We have such an opportunity to spend time with people. Why are we bending that just to make insurance companies happy? And, I hate to say it, what can we do to try to get away from that? Is it cash based? It's not cash based for everybody. Is it Is it something else? I don't have the right answers there, but I see the trend, heading in that direction. I think it's tough for new grads.
Yeah, no, I share the similar concerns. I think debt load, and then the choices after school, and I get it. Like I was listening to a podcast of Alex Hormozy. He's a business guy, but he's got some good instinct or some wisdom being a young guy. Even I think he's only in his 30s, but he talked about how people either choose money when they come out, and then you lose the ability to get mentorship because you need to be a revenue producing individual. Like, so if you go out first shot, you're going to go run a clinic because there's a lot of places that might even offer that to you as an incentive to get a little bit higher pay.
Yep.
But then you're on an island, man, and that island can be lonely, and it doesn't allow you the growth. I mean, for me, I was fortunate in good chunks of my career. I was able to get mentored somewhat along the way, but obviously fellowship was the big kickstart on that. But yeah, I just think, I get the decision. That's a tough one though. Like, hey, I got $200,000 worth of debt and I got to pay this off. Choosing finances over maybe the perfect clinical scenario. That's a tough one. I would like to say I would have, took a little less to learn a little bit more, but I also didn't have that debt load on my for myself. So
yeah.
I appreciate your time tonight, Mark. It's always a good time talking to you, man. We could probably wrap on this stuff and make like 6 episodes worth, but I want to respect your time. And I really wanted to thank you for your friendship and really appreciate, all the things you're doing at Bellin. And, I think Julie obviously is probably proud of the hand she's left it in with the EIM fellowship. I always just see you guys doing nothing but good stuff. So thanks for your time tonight, man.
Dude, appreciate the opportunity, and same to you, man. It's been a pleasure having our friendship and being able to talk these complex topics. But I always feel like I leave, even just listening to your podcast, just leave with, a little bit of a challenge, a little bit of thought. And I've always, back in the day when you were doing the EIM blog, your posts were always just, you're a hell of a writer, man. So I appreciate you just, you're a voice of reason, and you're a voice, I think, of professional, thoughts that make us think a little bit harder. So that's what we need.
Yeah, I appreciate it, man. I think we try. I don't try to go like full. I really appreciate Adam Meekins. He takes a little bit more of a abrasive approach, and he's done some great things, man. I really think he's stimulated some good stuff, but I don't really have that in me as much. But thanks to him for doing all he does. But yeah, man, much appreciated for your time tonight. Keep doing what you're doing, and hey, for those of you listening, if you check out the show notes, you'll see where Mark's at. And if you want to get in touch with him and ask him any questions about how to get mentorship or maybe get involved in a fellowship like Bellin's, definitely hit him up. Definitely reach out to us on social media if you have any other questions or concerns. And otherwise, we will talk to you guys and see you next week.